Hello there, and welcome to the deep dive. Pregnancy is, well, it's an incredible journey, isn't it? A time of huge change, lots of anticipation. But sometimes, along with all that excitement, unexpected health things can pop up. And like getting a medical diagnosis during pregnancy can sound pretty alarming. I get that. But really understanding what's going on is it's the first step to feeling more informed, more in control. So today we're taking a deep dive into three conditions. They're common, sometimes a bit complex, and unique to pregnancy: preeclampsia, gestational hypertension, and gestational diabetes, or GDM. Our mission here is really to cut through the noise, give you the essential insights you need without drowning you in medical jargon. Think of it like a shortcut, yeah. A shortcut to being genuinely clued in and prepared.
Absolutely.
Yeah.
And that shortcut is, well, it's crucial because while all three are pregnancy specific, they often clear up after the baby arrives. They do significantly increase risks for both the birthing parent and the baby during the pregnancy itself. So awareness, catching things early, managing them properly, it's not just important, it's absolutely vital for good outcomes.
Okay, let's start with preeclampsia. It's a term lots of people have probably heard, but it often gets boiled down to just high blood pressure. What's really happening in the body, though, and what are the key signs we should, be aware of?
Yeah, that's a great question. Because preeclampsia, it's actually far more complex than just high blood pressure. Think about your body's plumbing system, right? Your blood vessels. What's fascinating here is that it fundamentally starts with how the placenta implants, how it embeds itself. If it doesn't quite, let's say, settle in normally, it sends out these signals. And those signals cause the mother's blood vessels to react, well, abnormally. This leads to this kind of widespread irritation, inflammation of the endothelium, that super smooth lining inside all your blood vessels. It gets roughed up, basically, all through the body. And that affects critical organs: brain, liver, kidneys. Not just your blood pressure readings. It usually shows up after 20 weeks, marked by new, consistently high blood pressure. We're talking readings like 140/90 or higher, taken, a couple of times. And coupled with those signs that organs are involved, often that's protein in the urine, but it could be other things your doctor's tracking. It affects roughly 2 to 8% of pregnancies worldwide.
Okay, that really clarifies it. It's systemic, not just a BP number. So if preeclampsia involves high blood pressure plus this organ stress, what about when you have the high blood pressure, but without those other organ signals? Where does gestational hypertension fit in?
Right, that's the key difference. Gestational hypertension, or GH, is basically that high blood pressure, same 140/90 or higher, on 2 occasions after 20 weeks. But crucially, without the extra signs of organ damage, like protein in the urine. It's often thought of as maybe like a warning stage, because while it doesn't start with organ stress, it definitely can progress. And it's certainly not just mild. Something like up to half of GH cases can actually turn into preeclampsia, especially if it shows up earlier in the 3rd trimester. So that really highlights why you need that consistent monitoring, even if the initial diagnosis is just GH.
Got it. Okay. And then the third one, gestational diabetes, GDM. This one's not about blood pressure, it's blood sugar. What's the core thing happening there, and why does it only show up during pregnancy?
The why for GDM is actually pretty elegant in a biological sense. During pregnancy, the placenta pumps out hormones, things like human placental lactogen, cortisol. And these hormones are actually designed to increase insulin resistance. It's a natural thing and make sure more glucose, more sugar is available for the growing baby.
Ah, okay, a supply mechanism.
Exactly. Protective mechanism. But for some individuals, their pancreas, specifically the beta cells that make insulin, they just can't quite ramp up production enough to overcome that extra resistance. And that's when blood sugar levels start to creep up, leading to GDM. Screening for it is standard prenatal care, usually with a glucose tolerance test, typically between 24 and 28 weeks.
Okay, so we've laid out what these three conditions are. Now let's really dig into why they matter. You mentioned increased risks. When we look at the potential impacts for both the parent and the baby, what are the really significant risks listeners need to understand?
Yeah, they each carry very specific and potentially serious risks. Let's take preeclampsia. For the parent, the big concerns are things like seizures, that's called eclampsia stroke, severe liver or kidney injury, or a rare but really serious condition called HELLP syndrome.
HELLP, what's that?
Stands for hemolysis, elevated liver enzymes, low platelets. Basically, blood cells break down, liver enzymes shoot up, platelets drop. It's dangerous. Fluid in the lungs can happen too. And for the baby, preeclampsia can mean restricted growth, low amniotic fluid, the placenta separating too early, that's abruption. And often it means needing an earlier delivery for everyone's safety.
Wow, those are incredibly serious potential outcomes. What about gestational hypertension? Are the risks similar or different?
Well, with GH, remember, you don't start with organ damage. but it's still significant. For the parent, the main worry is it escalating to preeclampsia, or just having dangerously high blood pressure spikes on their own, which carries a stroke risk. Plus, having GH increases your risk of developing chronic high blood pressure later in life after the pregnancy. For the baby, GH can contribute to growth issues, placental problems, and higher chance of preterm birth. So definitely not something to brush off.
Understood. And the key risks with gestational diabetes for parent and baby.
Okay, with GDM,
Yeah.
for the baby, a big one is higher birth weight. Macrosomia, it's called. And a bigger baby can sometimes complicate delivery, leading to things like shoulder dystocia, where the baby's shoulder gets stuck. Babies might also have low blood sugar right after birth or jaundice. And looking longer term, they might have a higher lifetime risk of obesity and type 2 diabetes themselves.
And for the parent.
For the parent, GDM increases the risk of developing preeclampsia during that pregnancy, increases the chance of needing a C-section, and importantly, it significantly raises their future risk of developing type 2 diabetes and cardiovascular disease later on.
Right. These are definitely significant considerations. But, and this is important, here's the good news, right? With early detection, with the right proactive management, the outcomes for both parent and baby are actually overwhelmingly positive most of the time. This isn't about causing fear, it's about being informed, being empowered to act. So, okay, you know the what and the why it matters. Now, the really practical bit, what can you do? What are the actual steps, the management strategies, if you find yourself facing one of these? Let's start back with preeclampsia.
Okay, for preeclampsia, management is pretty comprehensive. Your care team, they're going to be focused on consistent blood pressure checks, obviously, and monitoring closely for those signs of organ involvement. So they'll run specific blood tests looking at kidney function, liver enzymes, platelet counts, and urine tests for protein. Fetal monitoring is also key, making sure the baby's handling things okay. Now, if your blood pressure gets dangerously high, like 160 over 110 or more, they'll give medications right away, often through an IV to bring it down safely. And in severe cases, there's a medication called magnesium sulfate. It's used to prevent seizures, the eclampsia part. And that might continue for around 24 hours even after the birth.
After birth too, right.
Exactly, because the risk doesn't vanish immediately. Now, the only actual cure for preeclampsia is delivering the baby and the placenta. So your doctor has to weigh the risks and benefits constantly to decide on the safest timing for delivery. That could be anywhere from 34 weeks up to 37 weeks, or sometimes even earlier if things are unstable.
Okay. So from the listener's perspective, the person going through this, what are the practical, actionable things they should be doing? If they're monitoring for preeclampsia or have a diagnosis, first off, really get familiar with your blood pressure numbers. If you're checking at home and you should use an upper arm cuff, not a wrist one, sit quietly for 5 minutes first. Keep your arms supported right at heart level. Take 2 readings a minute apart, log them. Call your doctor or midwife if you get 140 over 90 or higher twice. And definitely head to urgent care or the ER straight away if it hits 160 over 110 or higher. Or if you get any of those sudden severe symptoms like a really bad headache that just won't quit, new vision changes like spots or blurriness or sudden chest pain or shortness of breath, don't wait on those. Second, keep every single prenatal visit and lab appointment. Seriously, they are your lifeline for monitoring. Don't skip them. And third, remember, postpartum preeclampsia is a real thing. If you go home and then you develop a new or worsening headache, vision issues, chest pain, trouble breathing, or really significant swelling, get checked out immediately. Go to the ER. This can happen up to 6 weeks after delivery.
That's such a critical point about postpartum. And thinking about prevention before it happens. If you're known to be at higher risk, maybe you've had preeclampsia before, you're carrying twins or triplets, have chronic high blood pressure, kidney disease, diabetes, certain autoimmune conditions, your doctor might actually recommend taking low-dose aspirin, usually 81 milligrams nightly, starting sometime between 12 and 28 weeks, ideally before 16 weeks. And in places where dietary calcium is typically low, calcium supplements might also help reduce risk.
Good to know about prevention. Okay, let's shift to managing gestational hypertension. How does monitoring and treatment look there? How's it different?
For gestational hypertension, or GH, the main focus is really close monitoring. Regular, accurate blood pressure checks home and clinic are absolutely essential. Your team will also do periodic lab tests just to make sure those organ systems we talked about aren't starting to show signs of stress, that it isn't progressing towards preeclampsia.
Yeah.
And they'll keep a close eye on the baby's well-being, too, with things like non-stress tests or growth ultrasounds, fetal surveillance, they call it. Now, if the blood pressure does become severely high, that 160 over 110 mark again, they will treat it promptly with medications, similar to how they treat severe preeclampsia. But for non-severe GH, where the pressure is high but not dangerously so, and there's no organ involvement, delivery is generally recommended right around 37 weeks. Waiting longer doesn't usually improve outcomes and just increases the chance it might turn into preeclampsia.
Okay, so for GH, the practical advice about home beam monitoring, keeping appointments, that all still holds true, very similar. But what about the longer picture? For anyone who experiences either preeclampsia or gestational hypertension during pregnancy, what's the long-term outlook?
All right, this is where that idea of an early warning system really comes in. Having either preeclampsia or GH significantly, and I mean significantly, raises a parent's future risk for cardiovascular problems. We're talking a higher chance of chronic hypertension down the road, heart disease, even stroke. It's like your body gave you a major heads up during pregnancy about your underlying vascular health.
Wow.
Yeah. So we strongly encourage planning for yearly check-ins with your primary care doctor after pregnancy, get your blood pressure checked, lipids checked, and really focus on those heart-healthy lifestyle choices. It's an investment in your future health.
That's a really powerful takeaway. Okay, let's tackle gestational diabetes management. Once someone is diagnosed, what's involved?
Right, GDM. So screening usually happens between 24 and 28 weeks, maybe earlier if you have risk factors like a family history or previous GDM. Once diagnosed, the first step, the first line of treatment, is almost always lifestyle therapy. This means working with a dietitian usually for medical nutrition therapy. That involves balancing meals, looking at carbohydrate timing and types, getting enough fiber and protein. Regular physical activity is also really helpful. Even just a 10 or 15-minute walk after meals can make a difference.
And the finger pricks?
Ah, yes, the home glucose checks. Typically, you'll check your blood sugar fasting first thing in the morning before eating, and then usually 1 or 2 hours after each main meal. Your care team will give you specific target numbers to aim for. Now, if lifestyle changes alone aren't enough to keep your blood sugar within those target ranges consistently, then medications might be needed. Insulin is often the preferred choice because it doesn't cross the placenta to the baby. But sometimes other oral medications like metformin or glyburide are used, though they do cross the placenta. And throughout this, your baby's growth will be monitored with ultrasounds. And sometimes extra fetal testing might be needed, especially if blood sugar control is tricky or if you're on medication. Delivery timing, it varies. If GDM is well controlled with just diet, usually between 39 and, say, 40.5 weeks. If medication is needed, it's often a bit earlier, closer to 39 weeks.
Okay. And the practical day-to-day for someone managing GDM, what are the key self-management things? Well, it really hinges on a few core actions. First, doing those glucose checks exactly as instructed. Second, meticulously logging the results, every single one. And third, sharing those logs regularly with your care team, usually weekly or biweekly. You'll pretty quickly start to see patterns, You'll learn how your body responds. Like, okay, that specific breakfast consistently makes my sugar go high. Maybe I need to adjust it. It's about learning and adapting. And crucially, know when to call your doctor or midwife or when to head to the ER. Things like persistently high fasting numbers, like over 95, despite trying your best, or repeated high numbers after meals. And also, really importantly, be aware of any signs of preeclampsia because GDM does increase that risk slightly. So know those warning signs too.
And connecting this back to the long term. The postpartum period for GDM is critical. For most people, the GDM resolves almost immediately after delivery. The placenta's out, the hormone levels drop. However, like the hypertensive disorders, GDM is a powerful early warning sign for your future health. You'll typically need another glucose test, usually the full oral glucose tolerance test, somewhere between 4 and 12 weeks after delivery to see if your blood sugar has normalized. And then, you really should be screened for type 2 diabetes every 1 to 3 years for the rest of your life. But there's good news here too. Things like breastfeeding, getting to and maintaining a healthy weight, regular physical activity, these can significantly lower your future risk of actually developing type 2 diabetes. GDM is a strong hint about your body's metabolic tendencies, but it's not a destiny.
That's a really important perspective. Okay, we've covered a lot of the medical ground, but knowing the facts, that's one thing. Actually living with the pregnancy complication, that feels very different. Let's shift gears now and talk about the crucial emotional side of things, the feelings, the stress, and the support that's available.
Absolutely. This is huge. For preeclampsia and gestational hypertension, the emotional roller coaster can be intense. You might feel real fear, am I going to have a seizure? Is my baby okay? There can be incredible frustration too, especially if you feel perfectly fine. But suddenly you're facing constant monitoring, maybe hospitalization or the prospect of a very early delivery that wasn't in your plan. Even just the anxiety around blood pressure checks themselves can sometimes make the readings higher. White coat hypertension, we call it.
Right.
So the best support often starts with clear education, really demystifying what's happening, helping you understand why all monitoring is necessary. Sometimes reframing it helps seeing the frequent checks not as a burden, but as proactive, vigilant protection for both you and the baby. Partner and family support is just invaluable, helping with daily tasks, tracking appointments, doing home BP checks together, and connecting with others who've been through it through peer support groups like the Preeclampsia Foundation can make a world of difference in feeling less alone.
Yeah, that connection is so important. And for gestational diabetes, the emotional journey can be just as tough, but maybe in different ways. Often there's this sense of like guilt or self-blame. Did I cause this? Was it something I ate? The daily grind of finger pricks is stressful, no doubt about it. And you can feel really isolated sometimes. Like when everyone else is enjoying cake at a baby shower and you're trying to figure out your carb count, it's hard. And for some people, if they end up needing insulin, it can almost feel like a personal failure, even though it's purely about biology not keeping up with pregnancy demands.
Exactly. That feeling of failure is so common and so misplaced. For GDM support, working closely with a dietitian is key, not just for the rules, but for building realistic, satisfying meal plans that don't feel totally restrictive. Diabetes educators are fantastic resources too. For the practical side, mastering the testing, learning about meal planning strategies, getting comfortable with insulin injections if needed. Having your partner or family on board, maybe eating similar balanced meals with you sometimes, can really help you feel less singled out. And honestly, if the guilt or stress feels overwhelming, reaching out for mental health support, talking to a therapist is absolutely a valid and helpful option.
That's great advice.
And maybe universally, across all these conditions, there are a few key emotional supports to remember. One is reframing. These conditions are not punishments. They're not your fault. They happen because of complex interactions between the placenta, your body's hormones, your underlying physiology. It's biology, not a personal failing. Practical help makes a huge difference. Partners stepping up with meal prep, helping log glucose numbers, driving to extra appointments, taking blood pressures. It lightens the load immensely. And acknowledging grief is important too. If your birth plan has to change significantly, maybe you need an induction you didn't want, or a C-section becomes medically necessary, it's okay to grieve the birth experience you imagine. That loss is real.
It really is.
And don't forget your care team. Nurses, midwives, social workers, they often know about local support groups or therapists who specialize in perinatal mental health. Ask them for resources. And finally, remember that the emotional impact can linger. Postpartum anxiety or depression is real and sometimes linked to a stressful pregnancy experience. Don't hesitate to seek postpartum counseling if you feel like you're struggling after the baby arrives.
Such important points. Okay, what a deep dive this has been. Let's try and quickly recap the absolute core understanding. Preeclampsia, that's new high blood pressure plus signs of organ stress. Gestational hypertension, high blood pressure only, but it needs watching because it can progress. And gestational diabetes, that's all about blood sugar regulation during pregnancy. All three need diligent monitoring, careful management. But, and this is key, with the right care, catching things early, most pregnancies still result in healthy outcomes for both parent and baby. Knowing those warning signs and acting fast, absolutely crucial.
Exactly. And maybe the biggest takeaway beyond the pregnancy itself is remembering those long-term implications we discussed. Having preeclampsia or gestational hypertension really does act as that powerful early warning system for your future cardiovascular health. It's a sign to invest in heart health moving forward. And similarly, GDM is a very strong indicator for future type 2 diabetes risk. It highlights the need for ongoing screening and lifestyle focus. So we really want to encourage you to plan for that ongoing follow-up with your primary clinician after pregnancy. Think of it as investing in your long-term well-being.
Couldn't agree more. These conditions, yes, they're challenging during pregnancy, but maybe you can view them as this unique early warning system, like you said, a nudge towards a healthier future. So maybe the final thought to leave you with is this. What proactive steps might you take starting now, today? Not just to manage things well during this pregnancy, but to truly invest in your future heart and metabolic health for all the years to come. That's definitely something worth reflecting on. Thanks for joining us on the deep dive.